Alaikum. Hi. Today we're going to talk about facial nerve and facial palsy. So, what is facial palsy? Facial palsy is damage to the facial nerve. The facial nerve being the seventh cranial nerve, which is a nerve that is originating directly from the brain, and it supplies the muscles of the face. So, what facial palsy is basically is that the muscles of the face they become depleted of any stimulatory input, because of which the face on the side of damaged nerve area becomes drooped, meaning the face completely drops, the eyelid drop, the nose area drop, and the mouth area drops, meaning the person is not able to stimulate the face and contract the face to its normal position, either voluntarily or involuntarily. So that's facial palsy, and it's estimated that 20 to 40 per 100,000 people can get facial palsy. The damage to the face can be permanent or temporary. Usually, a person can recover some or all functions of the face within a few weeks to 6 months. The most common type of facial paralysis is Bell's palsy, which is temporary type. So the nerve can be damaged either centrally or peripherally. Centrally meaning damage to the nucleus above level of the nucleus where the nucleus resides. Basically, the nucleus of the facial nerve resides in the brainstem pons area, and the peripheral is the type of facial nerve palsy in which damage is below or at the nucleus area. And here is a pic that is demonstrating how a person of facial palsy looks like. You can see a normal, and on the next image, you can see the route from which the facial nerve travels from the brainstem to the face and supplies the areas of the brain of the face. Okay, so what is the course, the pathway, the track of the facial nerve? The facial nerve nucleus is located in the pons area of the brainstem. It keeps on going and winding route before exiting the skull through the stylomastoid foramen. So it basically divides into intracranial and extracranial. So the intracranial meaning it goes towards the brain in the cranial cavity, cranium, and extracranial meaning it goes towards the face outside of the skull, outside of the cranium, and towards the face. So intracranial, after nerve rises from the pons, it breaks into sensory and motor nerve root. It travels internal acoustic meatus, a 1 centimeter long opening in the petrous part of the temporal bone. Here they are in very close proximity to the inner ear. Still within the temporal bone, the nerve root enter in the facial canal, which is a Z-shaped structure. And here you can see in the pic that the motor and the sensory root, they are combining in the facial canal and forming the facial nerve again. And here the facial nerve forms a geniculate ganglion. A ganglion is a collection of nerve cell bodies. And it gives off three branches: greater petrosal nerve, which is a parasympathetic fibers to the mucous glands, and the lacrimal glands, meaning the mucous glands are basically secreting glands, basically mucus, and lacrimal glands are basically salivary glands, basically tear glands. They are tear glands. Nerves to stapedus. Stapedus is a muscle, and it's located in the ear. And chorda tympani. The chorda tympani supplies the anterior two-third of the tongue. It gives sensory supply to the anterior two-third and the parasympathetic fibers to the submandibular and sublingual glands. These are basically the glands that make up the saliva in our mouth. Now we have the extracranial root. After exiting the skull, the facial nerve turns superiorly to run just anterior to the outer ear. The first extracranial branch to arise is the posterior auricular nerve. It provides motor innervation to the some of the muscles of the ear. Immediately distal to this, motor branches are sent to the posterior belly of the digastric muscle. This muscle is responsible for raising the hyoid bone, which is located in front of our Adam's apple. And it also supplies the stylohyoid muscle, which is the muscle of the neck. The main trunk of the nerve, now termed the motor root of the facial nerve, continues anteriorly and inferiorly into the parotid gland. The facial nerve does not contribute toward the innervation of the parotid gland, which is innervated by the glossopharyngeal nerve. Now the glossopharyngeal nerve is the ninth cranial nerve within the parathyroid gland. The nerve terminates by splitting into 5 branches. The temporal branch, which innervates the frontalis, orbicularis oculi, and corrugator supercilii muscles. Zygomatic branch, which supplies the orbicularis oculi muscle. Buccal branch, which innervates the orbicularis oris, buccinator, and zygomaticus muscle. marginal mandibular branch which supplies depressor labii inferilis, depressor anguli oris and mentalis. And last we have the cervical branch which innervates the platysma. Here is a pic which shows us the innervations of the branches. And here we have a parasympathetic supply of facial nerve. And here we have in this pic a dissection, uh, a dissected body, and you can see the area where the facial nerve can be located and its branch can be located. Causes of peripheral facial palsy. There are two causes of peripheral facial palsy. First one is upper motor neuron ligand, and the second one is lower motor neuron ligand. So, what are the causes of upper motor neuron ligand? Stroke, intracranial tumor, multiple sclerosis, syphilis, HIV, vasculitides, meaning vascular problems, hemorrhage. And what are the causes of lower motor neuron ligand? They are Bell's palsy, tumor, infections, and iatrogenic facial nerve damage, trauma, congenital. Okay, so what are the risk factors? Diabetes, ear infection, hypercoagulation, increased blood pressure, ear infection, upper respiratory tract infection, obesity. What are the sign symptoms? So a person who either is having facial palsy or he now has facial palsy, the sign symptoms are inability to close affected eye, inability to move affected lip, at rest, drooping occurs on the affected side of the face, ectropion, difficulty eating and drinking, lack of lip seal, reduced clarity of speech, lack of tears, hyperacusis, altered taste sensation, and here's a difference in upper motor neuron ligand and lower motor neuron ligand facial palsy. If forehead is not affected, then it is an upper motor neuron ligand. And if the forehead is affected, meaning a person cannot lift his eyebrows, then it is a lower motor neuron ligand. And mentioned in some researches that in cases of upper motor neuron ligand, in cases of lower motor neuron ligand, there is also somewhat disturbance in the sensory or motor function in the thumb, wrist area as well in cases of lower motor neuron ligand. Okay, now we have diagnostic procedures. We have audiogram, and we have nerve conduction studies, computed tomography, MRI, EMG. What are the medications? The medications are in case of infection, antibiotic or antiviral. Other than that, corticosteroid, prednisone. Prednisone is always must given to a person who has Bell's palsy or facial palsy. So what are the treatment? The treatment is first medication, and other than that, you can go for surgery if you want to. And the third one is physical therapy, and physical therapy helps to improve facial muscle activity, helps to improve the symptoms of this disease, and it helps in recovering the patient's loss of muscle activity. We basically do a lot of electrical stimulations to try to rejuvenate or the nerve, rehabilitate the nerve. And I in my internships I used to see a lot of facial nerve damaged patients, and mostly they would recover in somewhat in a month or two when doing physical therapy. And if you don't do physical therapy, then the problem, it varies from person to person. The time duration varies. So we can help in reducing the time duration of the disease. That is the topic for today, and thank you all.